Next slide, please. Before we jump in, I want to take a few minutes to review a few housekeeping items. First, you can download a copy of today's slide on our event webcast site at https://events.westat.com/CAHPS/webcast. If you're having any issues with sound coming from your computer audio, you can connect to our webcast audio using your phone by selecting the Call Me option. You'll be prompted to enter your phone number, and then you will receive a call from Teams. Alternatively, you can click on the phone call to find the dial-in number and meeting ID. If your computer freezes during the presentation, you can try logging out and logging back in. That often fixes the problem. At any point in today's webinar, you may ask questions. Please use the Q&A icon and enter your question into the Q&A box. Once you've typed your question, click on the Ask button, and your question will be submitted to our panelists. We encourage you to share your name, your role, the name of your organization when you ask your questions. It just helps to set the stage. Speakers will respond to questions during the Q&A portion that will take place at the end of this webcast. Please note that the raise hand and chat features are disabled for this webinar. If you need to step away at any time, you can rejoin using the link provided in the email you received when you registered. And finally, if you have colleagues who are not able to join us today, or you want to re-listen to any portion of the webcast, a replay of today's presentation, along with the slides, will soon be available on the AHRQ CAHPS website. Next slide, please. Here's a quick overview of how we'll spend the next hour. We'll begin with a welcome from AHRQ and some background about CAHPS surveys that will help to set the stage. Then we'll dig into our main event, the new CAHPS End-of-Life Care Survey. We're going to hear from developers along with insights from one of our survey users. We'll end our call with a question and answer session where we hope to hear from you. And again, reminder to use the Q&A icon for that. Next slide, please. I'll just briefly introduce today's fantastic crew of speakers. Jonathan Bakdash will kick us off today. He's a social science research analyst at AHRQ. He works on both the CAHPS surveys as well as the surveys on patient safety culture. Rebecca Anhang Price is a senior policy researcher at RAND and one of the leads in developing the CAHPS End-of-Life Care Survey. Melissa Bradley, another one of our development leads, is the associate director of the RAND Survey Research Group. And we're also joined by Susan Wang, the National Medical Director for Palliative Care at Kaiser Permanente, where the End-of-Life Care Survey has been fielded. So John, with that, I'll turn it over to you to get us underway.
Thank you so much, Stephanie. Next slide, please. Welcome. Thank you for joining us today. I'm going to give you a brief overview of the AHRQ, the Agency for Healthcare Research and Quality, and some general background information about the CAHPS program, Consumer Assessment of Healthcare Providers and Systems. And if you have any questions, please feel free to contact me at jonathan.bakdash@ahrq.hhs.gov, jonathan.bakdash@ahrq.hhs.gov. Next slide, please. So a little bit about AHRQ. AHRQ is a research and development agency, and we're part of the U.S. Department of Health and Human Services. We invest in health systems research and evidence to help improve the quality of care and make care safer, create tools to improve practice improvement for healthcare providers. We also collect data and perform analysis to track and try and improve the performance of the U.S. healthcare system. AHRQ is not a regulatory agency. We recommend use of our products, but we do not require them. We do not implement policies for payment or reimbursement. So if there's a requirement to use an AHRQ product, it comes from another organization. Next slide, please. Tell you more about the CAHPS program. The CAHPS program focuses on advancing the science of measuring and improving patient experience. And the program has been around for over 35 years. And patient experience is what happens during a healthcare encounter to patients. What is their experience? We would contrast that with satisfaction, which is how they feel about the experience. So the CAHPS program develops validated surveys for high stakes purposes, such as public reporting, reimbursement. We also have supplemental questions, including narrative items. And then we have resources for quality improvement to make changes to improve patient experience. We develop and provide voluntary databases for selected CAHPS surveys, and we're really focused on the research for the science to advance patient experience measurement and improvement. We provide a number of free materials, technical support, and other resources. Next slide, please. So I talked a little bit about this. What is patient experience? And you can see that these are all the different domains. So it's things like, how well is the care coordinated? Were you treated with courtesy and respect? Did you get the information you needed? And we ask more detailed questions about this in a variety of ways. And these are just some elements of patient experience just to give you a sense, but it's really about what happened during a healthcare encounter, not expectations and not feelings about the healthcare encounter. Next slide, please. The general CAHPS principles are focusing on what is important to patients, what they want to know. And when the surveys are developed, you're going to hear more about this, but it's really the stakeholder and user input are very important to understand what the instrument should focus on. Surveys go through an extensive testing process, and they're standardized so you can compare results over time. And all of our surveys, tools, and resources are in the public domain, so they are available to anyone who would like to use them. Next slide, please. And this is just to give you a sense of the different main areas for CAHPS surveys. It's experience with providers, experience with facility-based care, and experience with condition-specific care. In this case, it's going to be condition-specific care for the end-of-life survey. And now I'm going to hand it off to Rebecca with the RAD team. Thank you very much.
Great. Thank you so much, John. Next slide, please. So I'm thrilled to be here today to introduce the CAHPS End-of-Life Care Survey. And this is a survey that assesses the full episode of healthcare that occurs in the last month of life, regardless of whether an individual was living at home or in a nursing home, and whether they received their care at their home or with their place of residence or at an outpatient facility or clinic. And by asking about all healthcare received in the last month of life, the survey captures not only care within each of these settings, but also transitions between settings of care, which we know can pose particular challenges for communication and care coordination and can often be burdensome to individuals and their families. So the respondents to the survey are informal caregivers, and by that I mean family members or friends of those who have died. And ideally, as many of you know, in CAHPS surveys, we like to hear directly from patients whenever we can. But the end of life is a unique situation that calls for a different approach. So first of all, we're looking to assess the entire last period of life, including the very final days. And since we're doing that, the survey by definition needs to be conducted after the person passes away. And since we can't know exactly when that will happen, it's also hard to target surveying in the last month of life. Arguably, individuals and their families have better things to be doing during that time, higher priorities during that time anyway. And so for those reasons, conducting a survey after some time has passed after the death is usually more appropriate. There's also some people who are not cognitively or physically able to respond for themselves in their final days, and we want to ensure that we hear about their care as well. And therefore, this survey seeks perspectives from their informal caregivers who are familiar with their care. Next slide, please. So as John mentioned, other CAHPS surveys assess experiences of care with particular types of health providers or plans and so on. So for example, the CAHPS Hospice Survey is part of a national quality reporting program, and it's used to assess care for the approximately half of all Medicare beneficiaries who die each year while receiving hospice care. And it's a very valuable resource for being able to compare the performance of one hospice to another. Similarly, AHRQ assesses experiences in the hospital example, Medicare CAHPS assesses experiences of care for Medicare beneficiaries throughout their trajectory of care, but doesn't have a specific emphasis on issues that are notable or more important at the end of life. And so by assessing end-of-life care across settings, we are also able to understand experiences of care transitions and focus on aspects of care that are specifically important at the end of life, like care preferences. And in addition, in our current policy context, we're moving more and more towards an integrated approach to care in general, and this is particularly true in serious illness care. So being able to assess across all settings, not necessarily attributable to any one specific setting, seems important in that context. So surveys that assess the last month of life have been developed for population level assessments for some time. So to look, for example, on a national level at what end of life care looks like and where strengths and weaknesses and opportunities for improvement are. But these surveys had not been designed bearing in mind considerations that are important when surveys are being used for accountability. So these are considerations like asking about care from a specific accountable entity that's responsible for paying for or overseeing care, and therefore can use the survey results for quality improvement within their own organization. So we designed that CAHPS end-of-life care survey for use by entities like integrated health systems, ACOs, accountable care organizations, Medicare Advantage organizations that are responsible for paying for or overseeing all care that a person receives at the end of life. Next slide, please. So development of the end-of-life care survey occurred over 5 years, spanning the pandemic. So first off, we conducted an environmental scan of measure databases and peer-reviewed and gray literature to look at what was already out there in terms of surveys that assessed serious illness and end-of-life care from the patient and family perspective. We identified priority content areas for the survey by convening technical experts and interviewing family caregivers, healthcare providers, and quality improvement leaders. And using these inputs, we drafted a survey and conducted more interviews with family caregivers, this time around cognitive interviews to ensure common understanding of our draft survey content. And we conducted a field test in the summer of 2022 among caregivers of patients who had died following receipt of care at Kaiser Permanente, and used that field test response data to test and finalize quality measures. Next slide, please. So to dig a little bit deeper into each of those steps, that environmental scan I mentioned identified 175 existing surveys that assess serious illness and end-of-life care. And we cataloged those surveys and their content into a bank of alternative approaches and questions to address each priority content area that our experts and interviewees informed us would be important to include on the survey. Click, please. So we convened a technical expert panel, as I mentioned, to elicit feedback on the goals and potential uses of the survey, what eligibility criteria patients and caregivers should meet in order to participate, as well as priority content areas for the survey instrument. And those panel members included representatives from entities that might be accountable for end-of-life care, like ACOs and MA plans, payers that might be responsible for overseeing delivery and quality assessments, settings of care in which end-of-life care is delivered, including nursing homes, hospitals, hospices, and home health agencies, representatives of advocacy organizations for older patients and families, and research and survey experts. And you can imagine as well that almost everyone also played the dual role of someone who had an experience as a family caregiver as well. Click, please. So these TAP experts suggested that the period of assessment on the survey should be 1 month, paralleling other surveys of end-of-life care, and because that provided a discrete and consistent window for assessment. They also highlighted 2 areas of content that speak to the uniqueness of this survey: the care team's attentiveness to the preferences of individual patients, as well as care coordination across settings. We then interviewed family caregivers whose loved ones had received care in several different settings. And what was notable about the results of those interviews is that there were certain aspects of care that were highest priority, regardless of the setting of care in which their family member had received care. And those included managing symptoms like pain, showing respect for the individual and their family, responsiveness of the care team to questions and requests for visits, and then many aspects of communication. When we spoke to healthcare providers and quality improvement leaders, their primary message to us was that soliciting patient preferences and trying to address them to the degree possible was key to understand in a survey of this nature. Next slide, please. So we drafted a survey guided by the priorities I just mentioned, and to promote consistency with existing initiatives and to ensure that we weren't reinventing the wheel, we pulled in previously validated CAHPS questions for any content area in which they existed, and then we heavily adapted or wrote new questions only when we needed to. In cognitive interviews with family caregivers of those who died in recent months, we tested variants of these newer or adapted questions on complex areas like shared decision-making and respect for patient and family wishes, preferences, and goals. And in addition, we wanted to ensure that respondents knew who we wanted them to assess, because again, we were considering all of the care across all of the settings in which the person had received care in the last month of life. And so we tested lots of variants of statements that helped to orient respondents to this idea. We conducted an observational field test of a draft version of the CAHPS End-of-Life Care Survey among bereaved family caregivers of patients who had recently died. And my colleague, Melissa Bradley, will share more details in a few minutes about how we identified these caregivers and administered the survey to them. She and her team had to think very carefully about this, as the information needed to conduct a survey of caregivers can be much harder to come by than the patient information that's usually used for CAHPS surveys, and different still from the CAHPS hospice survey in that across a range of settings, there don't tend to be records kept comprehensively about caregivers. We used field test response data to describe the psychometric properties of the proposed quality measures derived from survey responses, including the degree to which the measures could pick up variation in reported care experiences across subgroups. And Dr. Wang from Kaiser Permanente will describe a little more of that later in this session. Next slide, please. So the final measures on the 37-item CAHPS End-of-Life Care Survey in many instances mirror those that we see on the CAHPS Hospice Survey, such as measures of timely care, communication, respectfulness, and help for symptoms. The End-of-Life Survey's Care Preferences measure includes a question regarding the degree to which healthcare providers involved the patient and family in decisions as much as they desired, and if they did the best they could to respect the family member's wishes and to honor the family member's desired location to pass away. And in cognitive interviews, we really heard about this idea of doing the best they could as being really important, because sometimes it's the case that even with the best efforts, it's not always possible to address a preference or a wish, but that effort needed to be there and perceived by the patient and family. So in addition to the evaluative questions shown here that were included on the final version of the survey, the field test also included questions about topics that were of interest to our field test partner, Kaiser Permanente, and future users of the survey may also wish to include some supplemental questions on these additional topics. So for example, the field test survey asked respondents about whether their family member received too little, too much, or the right amount of medical care in the last month of life. And in a few minutes, Dr. Wang, our field test partner from Kaiser Permanente, will describe how her organization used that question. So with that, I'll turn things over to my colleague Melissa to talk more about the field test and some of the unique features of administering a survey to family caregivers following the death of a family member. Thank you.
Next slide, please. Thank you, Rebecca. I'm now going to describe the field test we conducted for the survey, and to add to some of the context that Rebecca already provided. For many surveys, we can fairly easily identify the respondent pool, and we usually have contact information for those individuals. For this survey, where we were interested in surveying not a patient, but a caregiver of the decedent, we needed to both identify a caregiver who was knowledgeable about the decedent's care in the last month of life, and also be able to reach that caregiver based on whatever contact information was available from the organization. So field tests help us in two ways. They help us to assess whether the survey captures the data we had hoped for, and they also help us to determine whether our plan for administering the survey is sound. That is, whether the mode we chose for administration, the timeline we allowed, and the available information we have about the respondents results in a reasonable response rate and quality data. In terms of the survey, our screener questions in the survey were meant to both remove ineligible respondents from the survey as a whole and to identify the appropriate denominator for evaluative questions. So we included questions that allowed us to remove cases where the respondent was not involved in the decedent's care, and also cases where the decedent did not receive care from a healthcare provider in the last month of their life. We also included a question on cause of death so that we could exclude decedents with traumatic death, things like accidents and injuries, if the decedent did not also have a chronic condition. We added this question since information on cause of death is not always available to organizations. To ensure that the appropriate denominator for evaluative questions was identified, we included screener questions that allowed respondents to skip evaluative questions, such as those on help for pain and other symptoms, if the evaluative questions were not applicable to the decedent's care. Another example of this was having the respondent skip the question on whether the decedent's wishes were respected if the respondent did not know what the decedent's wishes were. Our field test showed that these items were working to appropriately capture the evaluative items and also to identify cases that should be removed in whole. With the results from the field test, we were also able to check for missing responses, which might indicate things like that a question was not appropriate for the audience. For instance, if the respondents were not the best source of information for the item. Other reasons we might find high levels of missingness is if the response categories are not inclusive or if they're formatting issues. For instance, if a question series runs across multiple pages or if skip instructions are not clear. Finally, in the case of our Spanish language instrument, missingness might occur if there are problems with the translation. In our case, there was no concerning missingness. Finally, during the field test, we also look for variance in item response. If there's no variance across the response categories for a given question, we might be concerned that the question is not interpreted in the way we hope, or perhaps it is not a useful question. However, sometimes even if a question shows little variance in response, it's maintained if it is a critical concept or even if a small amount of variance is important to capture. Again, luckily in our case, there was no concerning missingness. When we also conduct a field test, it's also important to assess the success of our protocol for administering the survey. We want to evaluate our mode of data collection. Primarily, are we reaching respondents? Do we have good contact information? And did we allow enough time to complete the data collection activities and to receive responses? Hand in hand with this is evaluating our response rates and our response by mode. Are we getting enough response for analytic purposes? In this case, our response rates were well within the ranges we have obtained with other surveys of caregivers. Next slide, please. Our plan for the end-of-life survey included a mixed-mode data collection, a single survey mailing with phone follow-up. We chose to conduct the survey with 2 modes since we know that mixed-mode data collection obtains higher response rates. We modeled this data collection after other successful data collections with caregiver populations, allowing caregivers to choose their preferred mode to answer the survey, be it mail or phone. Our mail survey packet included a personalized cover letter, a survey, a posted paid return envelope, which are all following best practices for data collection. We sent a mail survey first and allowed 3 weeks for those surveys to be returned. For caregivers who did not return a mail survey, trained interviewers then followed up by telephone over a 3-week period. So it's important to conduct mixed mode data collection in this type of a staged manner, as research has shown that when offering multiple modes at the same time, it can actually reduce response. We fielded the survey in July through August of 2022 to 1,700 cases, and our response rate was just over 30%. Next slide. I also just want to take a minute to highlight the steps we followed to create the survey sample file. First, we randomly sampled individual caregivers of decedents aged 18 or older who died from July through November of 2021. The 1,700 cases we sampled were split evenly across the months of death. We required sample decedents to have at least 2 visits with a healthcare provider in the last year of life to ensure that there was a minimum amount of care for respondents to reflect upon when answering the survey. Secondly, we identified decedents that had caregivers with some sort of contact information, either a mailing address or a phone number. We sampled one caregiver for each decedent, and in instances in which a decedent had more than one listed caregiver, the primary healthcare decision maker was prioritized as respondent. Note that we also excluded caregivers with addresses outside the U.S. Next slide, please. This slide details some of the challenges we experienced in identifying and surveying caregivers. In our sample, caregivers all had telephone numbers, but not all had addresses. We reasoned that the caregivers were most likely to be spouses or children of the decedents. Thus, when there was no caregiver address, we elected to send the packets to the caregiver at the decedent's address rather than remove all cases without addresses from the sample file. We also had a subset of cases where we only had the first name of the caregiver, not the last name. We elected to send these cases to the telephone mode only to allow our experienced interviewers to negotiate this issue verbally. Finally, in terms of determining language of administration, we did a few things. We had information on whether the decedent spoke or read Spanish, but we were not sure how complete this information was, and of course, we did not know if this was true of the caregiver. It did, however, mean that the household of the decedent was probably Spanish speaking. So in these cases, we chose to mail both the Spanish and English materials to the household. And we also made sure that telephone staff included bilingual interviewers and that interviewers were trained on both English and Spanish materials, and that our computerized telephone survey was programmed to allow to easily switch between administering the survey in either English or Spanish. Next slide, please. So there are many guidelines for survey data collection, and I encourage you to review the AHRQ website that provides a great deal of guidance on administering CAHPS surveys. In the few minutes I've left, I'll just cover a few items that were key to this survey. The first is in terms of identifying the sample. We didn't limit ourselves just to one system or record level definition for the caregiver. Doing this would have excluded more records than needed to be excluded. We expanded the list of variables to look across a variety of positions, and our caregivers were, for example, noted as primary healthcare decision makers, named in advance directives, and/or listed as emergency contacts. We also made an effort to clean the sample file before fielding, including properly formatting addresses for mailing and removing duplicate cases. We also took pains to develop a survey that was easy for respondents to complete in hard copy form and properly adapted to read over the phone. There's much in the literature on best practices around instrument design, and we followed those closely, including such things as attention to formatting and using simplified language where possible. The materials we sent with the mail survey included a postage-paid return envelope and a well-formatted, easy-to-read letter, which included a clear description of the study and proper assurances. Finally, our Spanish translations were conducted by experienced translators using best practices for translation. During the field period, we allowed enough time to receive responses from each of the modes. In the mail mode, 3 weeks allowed for most completed mail surveys to be returned prior to the start of the phone calls. The calling period lasted 3 weeks, allowing us to call caregivers over a range of days and times. Phone interviewers were trained not just on administering the survey, but on general interviewing skills and in being sensitive when calling households that had recently experienced a death or that included elderly respondents. In addition, interviewers were provided with a frequently asked question sheet so they could address any questions raised by respondents in a clear and consistent manner. Next slide, please. So for more information about the CAHPS End-of-Life Care Survey, including English and Spanish materials and guidance on sampling, administration, and scoring, please go to https://www.ahrq.gov/CPXP CAHPS/INDEX.html. You can also find results of our survey field test in the May 2025 Journal of Palliative Medicine. Or feel free to contact Rebecca or myself at RAND at ranhgp@rand.org or mbradley@rand.org. Thank you.
Before we move on to our final presentation, we wanted to just get a little bit of feedback from you. So you should have seen a poll question pop up on your screen here. So we're curious, what do you believe is the most valuable potential benefit of the CAHPS End-of-Life Care Survey? Please go ahead and select one of these responses, and we'll pause for a moment to gather feedback from those of you on the line. We'll give it maybe just another moment or so for folks to respond. From what we see so far, looks like providing actionable feedback for quality improvement is the thing that comes to mind for most of you, though increasing transparency for patients and their families and supporting informed choices is also certainly in the mix in terms of potential benefits of this survey. We'll give it just maybe another 30 seconds so folks can register their votes. Perfect. And thank you for that. Appreciate your input. Quality improvement right now seems like it's the key feature that you all really see as a potential benefit of this survey. So with that, let's go ahead and turn it over to our very last speaker to hear a little bit about administration within the Kaiser Permanente context. Over to you.
Wonderful. Thank you, Stephanie. So my name is Susan Wang, and the best way to reach me would be by email. That address is Susan, SUSAN, .e.wang, W-A-N-G, @kp.org. You can go to the next slide. So at Kaiser Permanente, or KP, we are very interested in the care experience for people at end of life, especially related to care transitions. About half of our decedents do choose hospice, which matches the national average and does mean that we're missing the full picture for all of our patients and families. We do have CAHPS surveys for hospice, but we haven't, prior to this survey, had insight into the end-of-life experience for those individuals who are not on a hospice service. We've also implemented various supports for high-risk patients, and we have been interested to evaluate the impact of those efforts. We created our own survey called ACEs, or Advanced Illness Care Experience, which is a way to assess living individuals facing serious illness, and we've administered it twice across our program. However, it's a costly process and requires a separate oversight process from our CAHPS system to ensure that we follow regulations and we are not over-surveying our membership. So participation in field testing for this survey was a great benefit for us, being that it's within the CAHPS architecture, but also gives us access to those survey results as well as patient-level data that isn't typically available through CAHPS normally. Next slide. As we work through survey administration, one of the key priorities, as you've heard a little bit from Melissa and Rebecca, has been to find the correct contact person. The two markets that we administered the survey in were Colorado and California. And these states, like many states, do not have next of kin laws for medical decision-making. And so within those markets, there's been a dedicated effort to capture the healthcare decision maker and our caregiver in the electronic medical record, which is good. So 90% of decedents did have that information available in the chart. However, as you heard, there's still opportunity for standardization, ensuring that we're putting that contact information in a centralized location so it's easy to find both for care delivery and also for the survey process. Our survey was given in the summer of 2022 for decedents who had expired the prior summer and fall. Since grief evolves over time and may affect the perception of care experience, the timing of the survey in relationship to the death event is important to consider. One change that could be beneficial is to offer bereavement support as we give the survey in the form of a condolence card or additional resources, just recognizing the significant event of the death of the individual. Can go to the next slide. So we had 1,700 respondents across Colorado and Southern California, and the average decedent age was 80 years old. About half were female, and almost 40% had cancer in the last year of life. Over 40% had an advanced healthcare directive on file. 75% of those who had specialty palliative care also chose hospice. Now, these decedents did expire in 2021, so there was likely a pandemic effect to consider as well. And here are some of the comments that we received. I feel like she got great care. I especially think the hospice care was excellent. The day she died, the nurse stayed with us all day and arranged everything that needed to be done. The care was so good that I am considering changing my healthcare to Kaiser. The next comment. I didn't know the severity of her complications. Her doctors did not have communication amongst them. I felt lost and unprepared. My mother had an addiction and there was a bias toward her treatment. I don't think she was always given good care because of that. I feel like the doctors failed to guide me with her care and what to watch for. If so, then I would have been better facilitated to care for her. And another one. From cancer patient to the beginning care plan to palliative care to hospice, all the healthcare workers, social workers, etc., kept changing. I had to keep going over it all over. I had to keep going over it all over and over. I had a literal phone book of numbers to call, and I lived on the phone. A patient should be assigned to one caseworker who oversees the process from beginning to end. I've never been so exhausted in my life, keeping track of it all. I had nothing left. So you can see some positive feedback and some opportunities for improvement in some of these comments. Go to the next slide. This slide shows that the most positive experiences on the right were with care preferences being met, emotional support, and treating the patient with respect. So opportunities for improvement were greatest with getting timely care, which, if you recall, includes getting needed care during regular office hours, plus weekends, evenings, and holidays. Next slide. This is a busy but important graphic because we are interested in care transitions, and this was a unique survey in that we were able to capture information about the experience across these different sites of care. So it stratifies the experience results by care setting at the end of life. And you can see that persons in a nursing home, which is the orange bar, reported a worse experience across all measures. That was important evaluation data. Go to the next slide. And here you can see that individuals who remained in one setting of care, which is the blue bar, had a better care experience than people who had transitions across sites within the last month of life, which is perhaps not surprising. So this is all helpful data for us as we think about quality improvement in our health system. Next slide. Other learnings that we had from our participation in field testing include an opportunity for us as a large organization to engage with residential facilities like assisted living or board and care. While these are not healthcare facilities, so we do not contract for elements of care delivery, they are an important resource for patients and families for them to understand treatment options. And so they may have providers within the residential facilities giving advice to patients and families. And so there's an opportunity for us to engage and make sure that we have coordination and alignment around those options for our patients. Also, many SNFs or skilled nursing facilities have an opportunity to improve end-of-life care. We heard from our constituents that visitation policies were inconsistent and could be established earlier and with greater clarity and communication. Again, this was in the pandemic era, so I know that visitation policies changed in the SNF setting and hospital setting across many institutions, but this was important feedback that can influence any kind of future event for the patient experience. And Kaiser Permanente has its own hospice service that delivers care in the community for people at end of life. Yet many patients and families could not differentiate which clinicians belong to KP or to external agencies. And I think it added to some confusion and the influence of maybe feeling like care isn't always coordinated with the primary care physician or oncologist. We also found confirmation that older adults with multimorbidity and frailty were not able to access hospice consistently, perhaps due to lacking a clear terminal diagnosis according to Medicare guidelines for hospice admission. And finally, we still have opportunities for communication training, coaching, and feedback. So we can advance. And so here are a few more comments. I understand why she wanted hospice care. When you are 90 years old, you should have that right. I called several times pleading to get her on hospice and they still said no. She died the next week alone in a hospital bed because they would not write the order. And the next comment. One clinician would always use the word unfortunately, not giving us any hope for the situation. So I think this is two examples of one where you have an older adult, maybe without a clear diagnosis, but evidently with frailty, perhaps multimorbidity, and who ended up dying but without hospice services. And another where there's feedback about communication. And we know that conveying difficult or limited prognosis can be difficult for clinicians, but being able to communicate in a compassionate way. And here's some excellent feedback from our respondent here. Go to the next slide. So potential applications for KP in the future include using survey along with member retention data. If you remember one of the earlier comments that we had, it was a positive comment about having a good care experience for their loved one and feeling like maybe they would want to sign up for Kaiser for their own healthcare needs in the future. And I'm sure that works in the opposite way for a negative care experience as well, whether it impacts their desire to stay with KP. So I think that correlative data could be really helpful for our organization. And care preferences are vital in a value-based model like KP. So goal concordance is a chief quality indicator for us. This is really looking at preferences that people communicate to their healthcare team and hopefully are documented, and our ability to align with those preferences as a health condition advances. So Rebecca mentioned that we were able, as part of the field testing, to do our own kind of subset understanding of our population. And we did investigate this, looking at drivers of too little or too much care intervention. So 79% of individuals reported the right amount of care, which is good. 18% said the care was too little, and 3% said it was too much. So it does tell us there's still opportunity for improvement, including communication, especially across those transitions with non-KP entities, like contracted facilities or settings where patients and families might be private paying for support. And there are also misconceptions about palliative care, which might mean that access is limited for some folks and or comes very late in the course of disease. So we also are interested in scaling and expanding our measurement strategy overall with the use of this survey and thinking about the other opportunities to investigate and improve quality. And it raised a question for us about specific discordant events. So, for example, if a person said they don't want CPR and they did get CPR, and then later they experience a bill related to those interventions, should that be reimbursed? So I know there's been discussion by IHI and others around whether a discordant event would be perceived as a medical error. So it does raise those types of questions for us. I think even especially if that care is given outside of our KP system, and we serve as the payer in those instances. Next slide. So in terms of the future, we are exploring with our survey teams the opportunity to implement this end-of-life survey at KP, and we do hope that there'll be a chance to adopt it. I think it provides a lot of useful information that we're very interested in and that we think can help improve our care delivery. And I think we're at the end of this section and we'll move on to Q&A.
Thank you, Susan. Incredibly helpful to hear about KP's use of this new survey and those quotes from patients themselves or family members themselves really help to kind of bring home that quality improvement aspect of the survey. So a reminder to folks to please use the Q&A icon. Type your question in and ask that. Press the ask button to submit it to us. We're going to get through as many of the questions as we can in the next 13 minutes or so. So I'm going to start by just reminding folks, if you joined late today, I mentioned at the top of the hour that a replay of today's webcast along with the slides will soon be available on the AHRQ CAHPS website. So if you didn't get the whole thing or want to pass it along to a colleague, that is an option for you. Turning now to questions for our presenters. First question, Rebecca, if I can put you on the hot seat to kick us off. How do the researchers, or how do you envision using the end-of-life care survey, and how does that fit in with hospice CAHPS?
Sure thing. Great question, and thank you for it. So as we've all mentioned, the CAHPS end-of-life care survey allows for assessment across all settings of end-of-life care, not just hospice. And so our hope is that it will be useful for organizations that are looking to understand or compare quality across the full episode of end-of-life care. So as many of you know, the CAHPS hospice survey is a required component of CMS's hospice quality reporting program. The CAHPS end-of-life survey is not required for any CMS quality initiative. But according to the official CMS guidelines for the CAHPS hospice survey, that survey should be administered prior to administering any other survey after a patient's death. So if an organization is interested in collecting end-of-life survey data, that survey has to be fielded after the CAHPS hospice survey is fielded to any caregivers of hospice patients. But we hope that its results will give a sense, and hopefully a comparable sense across many of the dimensions that are measured on both surveys, of what care look like across settings, and again, incorporating any transitions of care that happened along the way.
Thanks, Rebecca. And Susan, I think you covered this a little bit, but just wanted to turn back to you and ask about what quality improvement work do you think could be driven by the results from this survey?
Yeah, happy to expand on that. I mentioned care transitions. I think especially for us with HEDIS, evaluating care coordination and looking really, if you see the data, the volume of transitions that our patients do experience, in looking at that a little bit further. So not just in the last month, but going back further, looking, are there settings of care that we didn't include that we might want to think about, and really trying to understand that more. I think that's very important because coordinating across transitions is challenging. What are the drivers? Is it a healthcare system driver? Is it a patient family driver? How do we help improve transitions or reduce transitions for better care experience? The other avenue for us, of course, is goal concordance, and maybe especially with the importance of collecting data here for our non-hospice participants, because that, again, has been an area that we haven't had good assessments for. So understanding, the preferences for someone who doesn't choose hospice could be different, and are we able to deliver what's needed, for those patients? So lots of opportunity to explore, as well as care preferences. And I think similarly, your non-hospice and hospice individuals at end of life, but also looking at the caregiver, what are the care preferences of the patient? Are they aligned? Are they communicated? Are they known to the caregiver? So understanding that space, I think, would be really helpful for our system as well, and in terms of improving quality of care.
Susan, can I keep you on the hot seat? There's a question that just came in. It feels like it's an add-on to that. Do you have any analyses or any insights into differences in experience based on whether the caregiver was a family member, hired caregiver, a friend, or any other type of support person?
What a great question. Yeah, I mean, we do have data on that, and many of the caregivers are family, for the purpose of our survey. So that's helpful to know. But I think it raises there's so much opportunity to explore the caregiver space, and I think, as you know, many people who serve in that role don't even identify as a caregiver. So as a health system, when you're collecting data, if we say, who's the caregiver, that maybe that's not the right question, to determine somebody in that role. So just lots of different questions about the data elements, and also, who are the right people to really evaluate, who are understanding the patient's experience. But yeah, for our purposes, they were mostly family involved in that space.
Thank you. And Melissa, I wonder if I can turn to you next here. And there's a question about the testing of the survey and whether questions and situations were tested with or found to be important with seniors with low incomes and their families.
Yeah, thanks for the question. I'll say that our survey content really was designed to be relevant to patients across the income spectrum. And when we did the cognitive testing, we were careful to include participants that were from a range of incomes and a range of education levels to ensure that the survey was relevant to them and also understandable to all.
Thank you for that. And there's we received a question here about the effects of the pandemic. And I don't know if any of the testing, either that the RAND team did or anything that you've seen from the KP side, give you any insights about kind of pre-pandemic versus, our lived experience since then, knowing that would have, those times are quite different in terms of what patient experience would have been and what that family engagement could have been through that time as well. I don't know, Susan, if you want to start us off, and Rebecca and Melissa, if you have insights you could add on.
Yeah, it's a super question. And I did point out, those years of involvement for the survey respondents. I think from a data perspective, there are probably some unknowns. And so we look forward to continuing the survey and continuing to accrue, this information. But certainly, in my role, we oversee all of our skilled nursing facilities. And so we're very familiar with some of the challenges. And in the areas where we had survey respondents and we had patients, there were really limited visitation overall. So families really were not able to access their loved ones physically for a period of time. And in 2021, even during that year, there were some challenges. So we did hear a little bit of that from the member reports, in terms of the visitation policies. And I would imagine that would extend to communication as well. You know, if communication is always done virtually or over the phone, you know, some things could get lost in translation. So I hope some of that has improved. Also, I think our skill set across healthcare has improved in terms of communication through telephone and video as well. We've all had a lot more practice, you know, communicating in this format, but I'm sure it had an impact, and I think there's been a lot of learning, certainly from the pandemic. I don't know, Rebecca, if you wanted to add anything, or Melissa as well.
Thank you, Susan. This one, I'm not sure, John, if you might have heard anything in your role, or Melissa and Rebecca, in terms of use of the survey. So we have a question about where it's being conducted, if we know. And just by way of reminder that John mentioned at the top of the hour, AHRQ doesn't mandate the use of surveys, so doesn't have a complete list. We're a little bit at the mercy of just being in touch with folks to know that they are administering it. But I don't know if Melissa or Rebecca, you have any insights into that, or John?
No, I would say sorry, go ahead. I would say at this point, we are not aware yet of individuals or organizations that are using the survey, but I'll again highlight that all of the materials are available now on the AHRQ website, and we encourage users to pull the materials down and take a look at them. We'd love to hear from folks who have used the materials or are planning on that, and we are obviously here as a resource if you have questions about that.
And I'll take this as an opportunity to also plug the help and support available through AHRQ and the CAHPS help desk. So this is an announcement and a bit of a promo for this new survey. So it would have had to have been some pretty early adopters to get their hands on it and field it already. But we're hoping that building awareness through things like this and having you all share this webinar and the slides with your colleagues, that we will have more interest. And certainly, please do reach out to us if you have any questions about the survey or about administration. There's lots of very rich information that is available on the AHRQ website. So please do check that out, and then reach out to us if you have questions. We're here to support. And so I'll just wrap us up here. I know we're nearing the top of the hour. So just wanted to invite folks to visit the AHRQ website and let you know that we periodically send email announcements about CAHPS news related to the end of life survey or other surveys, other products or events. If you're interested in receiving these updates, you can sign up by going to the top right corner of the AHRQ website and choosing the email updates associated with CAHPS. Next slide, please. So I had mentioned that the slides and a replay of this webinar would be available on the AHRQ CAHPS website. So here you have some contact information. So you can contact us by email at CAHPS1@westat.com, by phone at 1-800-492-9261, or through the website www.ahrq.gov/CAHPS. So we look forward to hearing from you and answering your questions and supporting you as you continue forward in your explorations of end-of-life care measurement. So with that, next slide, please. That concludes today's presentation, and thank you very much for joining us. We really appreciate this hour of your time. Wishing you each a very great afternoon. Thanks all.